So good morning. Thank you for coming. I am John Lynch. I'm the Medical Director of Employee Health and Infection Control. I work with a great team of folks here in Employee Health and Infection Control, one of whom is Vanessa McCarowitz in the front row, who's our Operations Manager. And I'm going to be spending the next, I think, 15 to 20 minutes kind of just giving you a background on the Ebola virus outbreak that's going on right now in West Africa and our response here at Harborview. So there's a bunch of firsts associated with this epidemic. One is, you can see the title is West Africa. Ebola has never really been a problem for the West African countries where you see them now. Guinea, Liberia, and Sierra Leone, which are those white countries up there in the left-hand corner. There are two of the countries that have been affected in this current epidemic, Nigeria and Sierra Leone. I'll just make it clear that the countries, Nigeria did have a fairly significant outbreak linked to a patient traveling from Liberia to Nigeria. And that has been now disease-free for almost 2 months. They're basically back to a level 1 or category 1 country with no cases, no contacts, basically outside the transmission window. Senegal had 1 case, no human transmission. So we're not going to really focus on either of these countries. We're really going to focus on Guinea, Liberia, and Sierra Leone. I will mention there's a second outbreak ongoing in the Democratic Republic of Congo, but again, we're not going to talk much about that. First outbreak in these areas, one of the things I'd like to mention is that these 3 countries share borders. It's really those where those 3 countries come together. These have a large population of individuals. The borders are quite porous. And what's very different about the epidemic that's going on in West Africa, besides the fact that it's been in these 3 countries for the first time, is that we have what's basically what we're regarding as an urban Ebola epidemic outbreak. So this has never happened before either. What we've always had in the past are these introductions of Ebola into small, generally rural communities, a number of people getting infected, a large number of deaths. But because they were limited in terms of the populations, people either died or got better and then it went away. And so when you put people with this disease into a setting where there's no health care, you get very high mortality rates, anywhere from 50 to 75% of folks die. This is what happens when this happens to you in the street or in your house. We don't know what would happen if you take 100 of these people and put them in the Harborview ICU or another ICU in North America or Europe. So we're gaining that experience, but it's a very high mortality rate, and probably even in the best circumstances, people die, as we learned from the unfortunate case in Dallas. So just quick takeaways about the virus itself. It's what's known as an RNA virus. It is not a hardy virus. And why it happens where it does is that it has a couple of cycles, one in fruit bats. We don't have these fruit bats here, so we don't have to worry about this ever getting to the animals here. This is what's called a zoonotic infection. You think about SARS, MERS, Ebola. These are actually influenza. These are all zoonotic infections. They're viruses that live in animals and then get into humans and kind of go back and forth. They get into more complex animal systems, and then humans hunt these animals for meat, and then in the process of butchering and handling and eating, get infected. And that's why you see in these rural communities where people depend upon hunting for protein sources and they get infected. The issues, those parts of Africa, just like the rest of the world, are undergoing incredible urbanization and getting more connected with roads and so forth. So people are able to travel from rural areas to urban areas back to rural areas to take care of loved ones, move around the country more easily. And these urban areas are closer to the wilderness areas where these animals are living and people are hunting. So you may have a hunter living next door to, an IT person. And so that's just like the rest of the world, nothing different. But this cycle doesn't exist in the United States or in North America. We're really focused on our humans and transmission. So let's take a step back to where this all started. This epidemic, although it's been on the national attention in the United States for about 3 months or so, this goes back to the springtime of 2014. This is March 14. This is really the first report. We think it's been traced back to one young man, a young person, back in Guinea. But here's the first report about 8 people dead and several others contaminated and unsure what was going on. There was evidence of bleeding, but this can happen with lots of diseases. There are lots of other hemorrhagic viruses, including Lassa fever, which is known there. Remember, they'd never had Ebola here before. So they were thinking about other things going on. So that's where things started in March. And I think the global health community basically said, okay, this is a small thing, may not be Ebola, and kind of let it go. Prior experiences, you remember, most of the time, by the time the public response gets involved, things are already on the way down. So let's jump ahead 6 months. This is when we started getting, as a global community, more aware of this problem. So we went from 8 people in March, and we really focus on the 3 countries we're worried about, Guinea, Liberia, and Sierra Leone. 800 cases, 2,000 cases, 1,300 cases. So in 6 months, a rapid increase in the number of cases affected, with about half the people dying. I mentioned the cases in Nigeria and Senegal. Those we're not going to talk about, but they did have an issue going there. And then an ongoing outbreak that's totally separate, only in rural areas in the DRC. That's ongoing right now with about 70 people. So if you just look at the dots, you can see how this is sort of spreading out. If you do want to look this up, there's a website that's free to everyone called healthmap.org, which you can push a play button and go through the whole epidemic. They also have reports, geographic reports on all infectious diseases, their reports. So it's a really nice site. So that's September 14th when I first started giving this talk. Here's October 14th, right? So that was yesterday. So we've gone from, up to 1,300 cases in Guinea, 4,000 cases in Liberia, 3,000 cases in Sierra Leone. So you're seeing a rapid increase in between when I first started giving this talk a month ago and now. I mentioned the Nigeria case, and we started adding countries like the United States, where we've had a new case diagnosed, in Spain diagnosed. In between yesterday and today, we've gone from 1 case to 3 cases. And just to be clear, this is in the setting of a disease that's affecting 10, 15,000 people right now in the world. And we're already starting to see the repercussions ripple out across the planet. And you can see the number of dots are rapidly growing. And this doesn't even include Europe, which has had several deaths in Spain from 2 healthcare workers, and a transmission event in Spain, and some other patients being taken care of in other countries in Europe right now. So let's just think about where this is going. So this is December of 2013. This is when I, again, started giving this talk. This was where we were a couple months, just let me see, last week. And the thought was we're right around 8,000 cases, with a projection by the end of the month to be around maybe 12,000 cases. The next slide is the same thing. It's a little bit smaller, and I apologize. I should try to make this a bit bigger. This is going up to 11/13. So this is 1 month from now, estimated around 18,000 cases. So what we see here is a sort of increase in the number of cases, a rapid increase in number, probably to do with greater attention and diagnosis and testing. But then that number just actually rate continues to increase. So we're not only dealing with an absolute number increase, but the rate with which we're diagnosing people is getting faster as well. Imagine when we get it to higher numbers, to 20,000. Or what's more concerning is, based on mathematical models, if nothing's done, by January up to 1.5 million cases. And that's a very big concern. If we don't get a hold of this epidemic now, by public health interventions, contact tracing, treatment, isolation, and so forth, this epidemic will continue to grow exponentially. And again, coming back to where we are now with less than 20,000 people affected, what will happen when 1.5 million people are affected, or even half that, 500,000 globally? It's a really tough situation, and it's not something that's going to go away as past Ebola epidemics have gone away. A small village affected, people die or survive, and it stops. This is not following that because of this urban situation. So just to put in perspective, we've known about Ebola virus since 1976 in a DRC outbreak. We've had a number of outbreaks over the ensuing decades, and this is the one we have here. Again, the first one in West Africa, the first one in these countries, the first one to be in urban areas, and it is by far the largest epidemic that we've ever had. Some of the basic facts to take away from Ebola virus infection. So from exposure to the development of disease, so that's the incubation period, 2 to 21 days, so it can be up to 3 weeks. People don't become contagious until they develop symptoms, and that's what we probably heard in the media. The patient in Dallas came to the United States on a flight feeling well, was fine when he got here, and then developed symptoms around day 4, and that's when he first showed up in the emergency room. And so up until that point, not contagious. That's why they didn't have to isolate everyone on the plane. They just started isolating people or doing contact tracing around the time of his symptoms. So 2 to 21 days, most of the time about a week. The reports that we're learning now, we're getting lots of information now from the Emory experience, hopefully the Nebraska case, and eventually from the Dallas cases, and from our colleagues working in West Africa about the disease course. We think 2 to 21 days, averages about a week. People seem to do pretty well for about a week, or do okay, and then get very sick around that time. The other big thing about this is that people think about Ebola hemorrhagic fever. They think about the hemorrhage and bleeding. Yes, there are abnormalities in their laboratories. Yes, if they vomit a lot or have other diarrhea or other output, blood may be involved, but that's not the problem. They don't get anemic. They put out huge volumes of diarrhea, some on the order of 5 to 10 liters of diarrhea per day. And as a result, it's more of a cholera-like disease where they have electrolyte abnormalities. So when people show up in Emory or medevac, that was the first labs they got. They were found to be hypokalemic, hypomagnesiemic, hypocalcemic. So all these electrolyte abnormalities that really needed to be repleted and then really focus on intravascular repletion, so lots of IV fluids. And there's, as we know now, there's no known treatments. You've heard about experimental treatments. One is a monoclonal antibody cocktail, ZMAP, that's been infused. We don't know how much of that's left. We think there's none right now. There's another drug called brincidofovir, which is used for the patient in Dallas. We don't know whether that had any benefit or harm. So I want to talk about how we protect ourselves and how we work with patients with Ebola. So it's important to recognize what we're seeing in the media and what we're doing. So this is what you're seeing in the media in West Africa. This man is ill. They don't know why he's ill. He may have typhoid, he may have cholera, he may have measles, mumps, tuberculosis, Lassa fever, he may have Ebola. They don't know whether he's going to throw up, have diarrhea, or get sicker right in front of them. They have to approach that situation with all possible precautions. This is a field situation, a field response. He's outside. They don't have the benefits of many of the things that our healthcare workers would have. And so that's why you see this, the ski type like goggles, full coverage, everything being covered. And that's what you're seeing in the media. It doesn't mean that what we deal with in the emergency room and ICU isn't somewhat chaotic, pressing, and anxiety producing, but it's not the same situation as being out in the field. The other thing that we know is that healthcare workers are being affected disproportionately in West Africa. There's probably about 400 or so folks who've been at least infected in West Africa, and part of that has to do with a lot of health workers not having access to the right PPE or the right education. And so, for instance, this man who's maybe handling specimens has this high-level respirator on and no gloves. Ebola is a contact transmission. It requires blood and body fluids getting into your mucous membranes or an open wound or something similar. People's blood, vomit, and diarrhea is infectious to begin with, and as they get sicker, more compartments of your body get more virus as time. So when you're very, very, very sick, many compartments and many fluids have lots of virus in it. Early on, they don't. But it still requires that contact. And so this doesn't do anything. It's not a respiratory virus like tuberculosis or a respiratory disease like tuberculosis or a virus like influenza. That's not going to help you. Gloves are what is going to cause the problem for this person. But this may be all he has. And so when we think about how healthcare workers are being infected in West Africa, we have to think about the conditions in which they are in, the access to the equipment they have, and the training that they've been getting. And then just to point out, as you all well know, Seattle is a global hub. We have a quarantine station here in Seattle. It's one of the 10 around the country. And we have a pre-existing agreement with Seattle-King County, Public Health, and the state at Harborview that folks who are identified as ill at SeaTac for any reason, there's a communication between that site and our hospital. Should patients arrive there sick for any reason, need to be taken care of, there's a communication with our emergency room and transfer of those folks. And people come in from all over the world into our state and our city and our airports, and may not be sick when they first get here, but get sick in the days after, and come in through our community partners, either our clinics, our specialty clinics, our urgent cares, our emergency rooms, and other places. And so we have to be prepared for all those sites, recognizing that we have an influx of people from all over the world coming in through Seattle. So planning. I say there's two things that we're focused on. One is our EVD plan. So we've had a plan in place for 2 months. This was developed with the input of all the experts in the room, and as we're learning, getting more experts involved from EVS, from food services, from engineering, from the laboratory, radiology, nursing, everyone we can get a hold of to get in that room, put it together. This plan is a living document. It is evolving based on what we're learning about the experiences in Emory, Nebraska, Dallas, including West Africa. So we are building on our experience as an international community and redoing this as it benefits our employees and our patients. The guidelines for transmission, preventing transmission, have not changed. And those protocols and those basic guidelines are the things we continue to follow. We are thinking about modifying some of these things based on were the nurses comfortable or uncomfortable in their care of patients in Emory. We learned about certain things that made them more comfortable. We found that they were in the rooms for 2, 3, sometimes 4 hours at a time. So how can we maximize comfort and effectiveness and safety in that situation? It may not be the double plastic gowns and N95. It may be something different in order to address that comfort. It doesn't change the level of protection aside from how we practice care at the bedside. So that's one thing, and it's how do we triage patients, how do we take care of patients. The other thing is talking to people. We all have to acknowledge that as every time I talk to folks, is that our family members, our friends are calling us and are worried. So we have to talk about the media in the United States. So this is what we've seen in Emory when the first person came in these full body hazard suits. And one of the things I just really want to point out is that how we use PPE is really important. What we think may be contributing to transmission to healthcare workers is how PPE is put on and removed, especially how it's removed. We think that the external part gets really contaminated, and how we take it off is super, super important. We have to recognize that how we take that off has to be done in a very specific way, and we've got a couple things hardwired to make sure that happens. One of the things we don't want to do is introduce brand new gear and brand new concepts. So for instance, in this case, and these guys may have drilled this way, but this, his cuffs are taped, his ankles are taped. I don't know how to take off duct taped stuff without tearing my gloves or tearing my suit and potentially contaminating myself. Now maybe they do, but that's not something we would do because we think that would increase your risk. So sometimes putting more stuff on makes it worse and isn't needed. And so what we have to know is what's the right stuff based on the biology and what is safe for our employees to use to get on and off. So we have a couple of levels of care. So I suspect that the most common situation for our hospital would be someone who meets clinical criteria, so that's very nonspecific, fever, headache, diarrhea. And what we're trying to do is put in triage protocols at our ambulatory care clinics, our contact center, and our ER, that if you meet any of those criteria, you simply get asked the second question. Have you traveled to one of the 3 African countries that are affected? If those things, both of those things happen, that patient's going to get masked and isolated, and we have the infection control protocol will be triggered. And so we've run through this in the emergency room. We're working on building a team on the inpatient side so that happens. If all those patients, if they get admitted, if they're going to get tested, they're going to get the whole thing's going to be put into place, and all those patients are going to go into a negative pressure room. If they're essentially well, then our hospitals team potentially would be taking care of them up front. And we could consider using droplet contact precautions. This is the same precautions we use for influenza, except we're using a full face shield as opposed to just eyeglasses. This is what the CDC and all other guidelines recommend, MSF and others recommend. If there's anything going on with this patient, though, we're probably going to reflex directly to more rigorous infection prevention protocols, and this is what also consistent with the CDC guidelines. Again, the person will always be in a negative pressure room, but we'll move to negative respirator contact precautions. That means, in addition to the full face shield, instead of a surgical mask, we'll be using a respirator, an N95 respirator, or a PAPR or PAPR-like hood. That would be able to protect everything in the face. If a nurse is at the bedside for a long time, wearing an N95 is very hard. And we're working on finding the exact best gear that is familiar to our healthcare workers so we can use the right stuff. And then on the inpatient side, building a team who gets trained, and then just-in-time trained and redone. And that we found that in some recent cases that's worked really well. So this is where we are right now. This doesn't mean that we stop at the nurses or the docs. So we got to train EVS. Our engineers are on board and working what's going on. We're working with how we handle all of our waste. We have a plan for how that's done. We're working on how we flush the toilets. We're working on how we handle every aspect of this care. And we recognize as we go through this process that every time we deal with one thing, there's a few more things behind it that we need to address. And so we're actively working on all those things. And I really value everyone's input on how we can improve this process or insight or groups that we haven't spoken to or communicated with so we can make sure that happens.